हम किधर बैठे?
बैठ जाओ आगे। मैडम इधर आ
Moral focus.
सही है।
Assalamu alaikum everyone. Please be seated. We are starting the session. Thank you so much for joining us today for the second day of the 42nd annual PSA conference. To begin with our scientific session today, the topic of the session is two case-based discussions on critical care and pain. For the first discussion, I would like to invite Dr. Fauzia to please come on stage and moderate the session.
Bismillahirrahmanirrahim. Assalamu alaikum, ladies and gentlemen. जहाँ मकतब की फ़िज़ाओं को दुआ मिलती है, जहाँ मकतब की दुआओं को फ़िज़ा मिलती है, वहाँ इल्म की भरपूर हवा चलती है। जहाँ उस्ताद सिखाते हैं हुनर जीने का, जहाँ उस्ताद सिखाते हैं हुनर जीने का, वहाँ ज़िंदगी भी जीने की दुआ करती है। इल्म रास्ता है, मेरा शऊर है मंजिल मेरी। इल्म रास्ता है, मेरा शऊर है मंजिल मेरी। मेरी हर सिमत फ़कत इल्म को निकलती है. Thank you. Ladies and gentlemen, a very good morning to all of you. I am Dr. Fauzia Khohavar, and I take the immense pleasure and profound gratitude to welcome all respected guests here today at 42nd Annual Conference. We are starting a clinical-based session, and which is inclusive of 2 case-based discussions. I would like to give a brief introduction of our session chairs one by one. The first chairperson, he completed his FCPS in 1987. He has served Pakistan Army and is retired as brigadier and professor of anesthesia. Served in Sindh Institute of Urology and Transplantation, SIUT, and Aga Khan University Hospital as a consultant. Presently, Chair, Department of Anesthesia, Pain and Surgical Intensive Care Unit at Indus Hospital Network. He's an examiner and a supervisor of anesthesia since 1995. Please give a big round of applause to a respected chair, Sir Professor Naveed Masood. Please join here, sir, on the stage. Ji, sir. The second chair of today is, she has been part of critical care and pain management for around 33 years. She completed her graduation in 1986. She's a member of College of Physicians and Surgeons of Pakistan. She's an integral part of education and academic activities. With her dedication, she became professor and head of the department, Civil Hospital, Karachi. A strong woman with passion, wonderful personality, and a kind heart. Please welcome respected Madam Professor Safia Zafar Siddiqui. Thank you, chairs, for joining us here upon the stage. Now I would like to hand over the session to our respected chairs, and they will invite the expert panel.
Assalamu alaikum. I would like to invite our expert panel, Dr. Faraz Shafiq, please. Dr. Faraz Shafiq. And other one is Dr. Asya Taqi. And the speaker is Mohammad Suhaib. He will present his presentation, then we will discuss it. Thank you.
Can you pull on the... Assalamu alaikum everyone, good morning. My name is Sohaib. I'm working as an assistant professor in Department of Anesthesia at Khan Hospital. So the task assigned to me was like a case-based discussion on a traumatic brain injury, a stepwise approach, like a patient admitted to an ICU, like first in ER. So I will go through a case and we will try to explore the different options we have to treat the traumatic brain injury in a stepwise fashion. Please try to engage in the discussion. I will try to ask some questions and want some answers, like what the people are doing in their settings as well. So the first slide is like I have no conflict of interest. So the objectives of talk will be today is like definition of traumatic brain injury and disease burden, early interventions for TBI, evidence-based TBI protocols and neuromonitoring techniques, which we have or like the people are developing outside, like in the West or in America. So the first slide is showing the definition. The CDC defines a traumatic brain injury as a disruption in the normal function of the brain that can be caused by a bump, blow, or jolt to the head or a penetrating head injury. The importance of giving the definition is that because they rule out any intoxication or medical illness that leads to traumatic brain, because to calculate the disease burden, they have to define the traumatic brain injury. So this is the definition by the CDC they follow. And there is another definition, because if you pull out on a search engine, so you will get like 10, 12 definitions of traumatic brain injury. So I have only defined the two, that traumatic brain injury, a form of acquired brain injury, occurs when a sudden trauma causes damage to the brain. This is by the National Institute of Neurological Disorder and Stroke. So a couple of two slides. What is the disease burden? These are the three main articles from which I have prepared my presentation. This is the Brain Trauma Foundation guidelines that were out in 2016, after which there was only one update in 2020 by decompressive connectomy, nothing other than that change of 2016. The others are like intensive care medicine article and an anesthesia article, which relates, like these two articles are published in 2023 and 2022, which gives the updates. So globally, the annual incidence of traumatic brain injury is variably estimated at around 27 to 70 million. There is a different disease pattern in high income countries, like elderly are more common, occurs due to fall. And in low middle income countries, there is younger, more common, most prevalent are the RTAs that lead to the admission to, lead to the traumatic brain injury and admission to the neurocritical care. And almost 2 million fatalities from TBI are preventable in low middle income countries. This is the data from the Pakistan. These are the initial results of Pakistan first road traffic injury surveillance report, which shows the incidence, mortality, and traumatic brain injury. And it's showing that the traumatic brain injury is leading to the 1/3 mortality of this all patients with the road traffic injuries. So this is quite a huge number. And the interesting thing was the underage drivers, like the mean age was like 14.7 years. This is the first surveillance report that came out to be. So now moving on to our case, there is like a 30 years old male on a motorcycle without a helmet, collided with a car while overtaking. This is a fictitious case I have just built and just to make a case presentation and see what options we have. He regained consciousness after remaining unconscious for 30 to 45 seconds, slow to respond, but no focal deficit, rushed to the nearby hospital by an ambulance. These are the vitals in an ER, like the pulses like 107, blood pressures. On neurological examination, the GCS was like 8/15. Pupils were reactive, no focal neurological deficit right now, periorbital hematoma and bruise behind the ear. This is a case which we usually see every now and then in our emergency departments, like the ambulance people carrying the patient to the ER. So my first question will be anybody from the audience, if you want to answer that, what the emergency department of traumatic brain injury patient, like what will we do in this patient? Anybody in from the audience or? Yeah, so sir rightly said that it's like the primary survey which will be doing like the initial emergency management of traumatic brain injury. So we will be doing like airway, breathing, circulation, disability, and exposure. So in an airway, we will be seeing that it's maintaining or not, and then if the GCS is low, then we need to intubate the patient. In the breathing, we will be saying either a hypoxia, hyperoxia, hypercapnia, and we think that we need to treat. Circulation, we need to see the blood pressures and then to the manage. Any idea about what should be the initial resuscitation targets that should be in the first hour of the presentation? Yes, sir. So.
May I just add here that apart from the ABC, we have to see, we have to take it for granted there is a cervical spine injury.
Yeah.
We have to do for inline stabilization till
Definitely.
the time it is confirmed later on.
Yeah.
Initial examination may prove to be something like initial tenderness on the spine and all that, but still always is better to be highly suspicious of this. So we have to cater for that also.
Yes. So I will be discussing in next few slides for the cervical spine clearance what we're gonna do. So sir rightly said that with this ABCDE protocol of the primary survey, we will be needing to rule out any suspected cervical spine injury as well. There are a couple of rules. I will just discuss that. Coming back to the same question, that what should be the initial resuscitation targets in the first hour of the presentation of the patient to an ER? Anybody have any idea that what should be the blood pressure should be, what should be the saturation or something like that? So I pull out this.
So initial, can I?
Yeah.
I can just add the initial resuscitation targets should be given during the initial first hour of the trauma. That is from the scene to the shifting of the patient to the ICU or any anywhere where the patient has to be moved. So initial targets, which the Brain Trauma Foundation, which we don't have our own guidelines, so we have to follow the Brain Trauma Foundation guidelines. And they say that why it is important? It's important because the initial injury, whatever the trauma has occurred, it cannot be transferred into the secondary brain injuries. It can lead to that. So we have to see the perfusion of the brain, which is important, and hypoxia, we have to nullify that, we have to give them oxygenation, and there are 4 to 5 factors which include saturation, which can be maintained with supplemental oxygen, around 90% or more we have to attain. The hemoglobin is more important. So hemoglobin has to be more than 7. And studies have shown that if we target it around 8 to 10, it's okay. But more than 10 is not desirable.
Okay.
And
Thank you. So we should,
anyone
like,
wants to
these are the initial first start
and
targets. Like,
hypothermia is not allowed. You have to
Yeah.
have.
okay, fine.
So, Sohaib Ismail, just one comment. So, it's very important for us to understand the golden hour of trauma. So, we have to go with the discussion as we go, or what do you want? Dr. Alia?
I think so. We need to go and then we can ask the question.
Actually उन्होंने क्वेश्चन पूछ लिया था इसलिए सब
Yeah.
हो रहा है.
So, audience, sir.
हाँ.
Fine.
Okay.
So the initial first hour, the presentation will be like the targets which we need for resuscitation to set are like blood pressure. The MAP should be like around 80, or it should be like there are like guidelines that MAP should be above 90 as well. Systolic blood pressure greater than 100 or 110 are desirable. Saturation greater than 90, if we need to give an oxygen, we should give it. End-tidal CO2 should be between 30 to 35, not hypercapnia, not hypocapnia. And hemoglobin should be greater than 7 because avoiding brain hypoxia, this directly linked to anemia. And anticoagulant reversal, if the patient is already on some anticoagulant, we can give the reversal according to what the anticoagulant drugs the patient was taking. So, rightly said, rightly pointed out that we need to rule out cervical spine clearance in traumatic brain injury. So there are actually 2 rules which usually follow in the ER. This is nexus criteria or Canadian C spine rule. So, but like mostly the nexus, we follow the nexus because it's easy to do. And in like Canadian C spine rule, we need to have an information about how the mechanism of the injury was. So initially, it is difficult to get the history of the traumatic brain injury patient from itself unless the relatives arrives or somebody else gives the history, what is the mechanism. So it's like the nexus rule, which is the most common one which we use. From the audience, what are the indications of CT scan brain in TBI patients? Anybody idea? Or everybody should be going under the CT scan brain? So,
Sorry, may I answer that? Sorry.
I think it's an audience, then we will have a discussion, yes. So, indications for performing CT in the acute setting will be like loss of consciousness, post-traumatic amnesia, persistent altered mental status, focal neurological symptoms, signs of skull fracture, or evidence of any clinical deterioration. So, we have to go for a traumatic brain injury. In our settings, like in the hospital which I work, we have a protocol that we give usually transamine. Anybody from the audience, do they give transamine, and what is the evidence of that giving in traumatic brain injury, or either we should not be giving it?
Anyone has
Anyone,
got,
any from the audience that they usually give, can you raise the hand, like everybody gives the transamine and ER to a traumatic brain injury patient? Or nobody gives it, like nobody is raising the hand. So, so what is the evidence of behind giving this? Was like there was a crash 3 trial in 2019 which gives like that if you give a transamine within like 3 hours of a traumatic brain injury, it decreases the mortality, and absolute reduction was 1.7. But minded that it was in like mild to moderate traumatic brain injury, not in a severe traumatic brain injury patient, because like if the GCS is less than 8, then transamine might not be helping in the mortality from the expansion of hematoma. But if it's like mild to moderate, then you can give like transamine within 3 hours of the injury. Coming back to our case, the patient GCS was 18/15, so the patient was intubated with manual inline stabilization and shifted to ICU for further management. CT scan showed the bilateral diffuse cerebral edema, and there was a right subdural hematoma tracking along the tentorium cerebelli. And there was no trauma protocol CT done which was showing no chest or abdominal injuries. So, what management strategies can prevent the elevation of intracranial pressure and secondary brain injury in an ICU? So, there is a Seattle tier-wise approach. So, we will be discussing the tier 0 approach. After shifting the patient to an ICU, there should be a head elevation of the bed to 30 degree. Head should be kept midline to facilitate cerebral venous drainage. Avoidance of jugular vein compression, analgesia and sedation according to the patient's GCS. There should be a liberal glycemic control that the glucose level should be around 180. We can target that. Target normothermia, saturation should be above 95. Early use of end-tidal CO2 if available. And serial neurological assessments are very important to see if there is any deterioration in the GCS. Second, I missed in the tier 0 about the seizure prophylaxis. Anybody from the audience, trainees, are the seizure prophylaxis indicated in traumatic brain injury patients?
Can I interrupt? Dr. Sohaib?
Yeah.
Seizure prophylaxis, because it's an interactive with us, so you are presenting the whole case.
Yeah. So
we have to, So anybody, seizure prophylaxis, is it prophylactic or you have to do? What is your protocol or any in your ICU? So guidelines, what they say? They say seizure prophylaxis should be done only if it is in the first 7 days. If the patient has, no prophylaxis should be given afterwards, after 7 days. So that's the Brain Trauma Foundation says. Let's see what. Yeah.
So for the seizure prophylaxis, it's usually indicated with traumatic brain injury. It's just for the prophylaxis for the first 7 days. The only thing was in our most of the hospitals, and the evidence says that people are using levetiracetam for the seizure prophylaxis. But Brain Trauma Foundation still holds this, that phenytoin is the drug of choice for the seizure prophylaxis. It should be continued for 7 days and then it should be stopped. It do not prevent from the post-traumatic epilepsy if the patient survive from the traumatic brain injury. But for the first 7 days, the seizure prophylaxis will be with phenytoin, but that data is coming with levetiracetam, but still it lacks. This is a slide showing the Brain Trauma Foundation guidelines comparing with Association of Anesthetists and National Institute of Health Excellence. So they say that for the blood pressure targets, if you see the Brain Trauma Foundation, they say the systolic blood pressure greater than 100 with age 50 to 69, systolic blood pressure greater than 110 if age is between 15 to 49 and greater than 70 years. On the other hand, Association of Anesthetists slightly changed that with systolic blood pressure greater than 110 to 150, MAP should be greater than 90, and the National Institute of Excellence greater than 80. Ventilation, we all know that we have to maintain normocapnia, no hypocapnia, no hypercapnia. In Brain Trauma Foundation guideline, there is only one single grade 1 recommendation, that is steroids should be avoided. And the other two guidelines, normally they are quiet about that. It means that either the data is low or either they have convinced with that there is a grade 1 recommendation, we should not use steroids for traumatic brain injury. Osmotherapy, there is from Brain Trauma Foundation, there is no clear-cut guidelines whether to use mannitol or whether to use hypertonic saline. But Association of Anesthetists say that we can give mannitol or hypertonic saline. There is still a large trial going on which will let us know that either we should give hypertonic saline or either we should give mannitol. Still, right now, you can give either mannitol or hypertonic saline if the institution have that. Temperature, there is prophylactic hypothermia and not. So, moving on. In traumatic brain injury patient, which patients need the intracranial pressure monitoring? So, Brain Trauma Foundation guidelines says that all salvageable patients with GCS less than 8 and they have an abnormal CT, they should have an intracranial pressure monitoring. And the other thing is if the CT is normal, but the age is greater than 40, if there is abnormal motor posturing or the systolic blood pressure is less than 90, then we need to have an intracranial pressure monitoring. I think so that in our setup, we don't have intracranial pressure monitors as well. So anybody having some intracranial pressure monitoring doing in their hospital? Normally, we usually do like through an EVD if the surgeon puts like an EVD, intraventricular drain. So we monitor the ICP with that. But like, so these are the options which are available, like intraventricular catheter, intraparenchymal catheter, subdural or epidural. Our surgeons have bought only one epidural, subdural bolt, which you usually decide to which patient they should be putting on. But normally, if the patient having an EVD, we monitor the ICP with help of that. But we don't have like fancy monitors right now in our setup as well. So I think so all across the Pakistan, there we don't have these like ICP. But what we can do is like we can do the optic nerve sheath diameter that correlates with the ICP. The problem is that if optic nerve sheath diameter is greater than 6, so it means the ICP is above 20, but we don't know how much above than 20. So it don't have a linear relationship, but it will only tell you that it's the problem with this is like it's an operator dependent. It cannot be measured continuously. And so these are the pitfalls in doing that. But it's like a good tool if we suspect that patient has raised ICP, we can do this at a bedside. These are the proposed target values for some neuromodalities like ICP, cerebral perfusion pressure, and the brain oxygenmetry. Brain oxygen tissue metry we will only do if we are doing an hyperventilation. So continue with the case. The patient was in an ICU, dropped the GCS to 6/15, and he was having hypertension, bradycardia, heart rate was 48, and the blood pressure 180/90. So now the next step would be like we need to initiate the tier 1 standard approach to treat raised ICP. This is a tier-wise approach is by the Seattle people, like they have done this like tier 1, tier 2, tier 3 for rescue ICP trials. So hyperventilation for a brief course, hyperosmolar therapy, mannitol or hypertonic as I've already said, and cerebral perfusion pressure of 60 to 80, and like surgical decompression if clinical sign of herniation does not resolve. So this patient like was having raised ICP, we moved to from tier 1 to tier 2 approach. We increase the sedation with propofol boluses that will be helping in like decrease ICP and cerebral metabolic demand. We started the vasopressor to achieve the target cerebral perfusion pressure of 60 to 80, and we target a PSU2 of 30 to 35. But still the patient GCS not improving, and we are suspecting raised ICP, so patient rushed to the operating room for rescue decompressive surgery. So these are the update from the Brain Trauma Foundation for in the 2020. This was the only one update. They have given the decompressive connectomy. So they recommend that a large frontoparietal decompressive connectomy should be done. And there were two large trials like DECRA and Rescue ICP. So they said that the secondary decompressive connectomy helps in reducing the ICP, but they do not improve the mortality and they do not improve the Glasgow outcome scale at 6 months. Continuing with the same case, the patient was moved back to an ICU, but the flap was tense after decompressive connectomy. So we have started the tier 3 approach, administration of barbiturates. Brain Trauma Foundation, that we can only use barbiturate as a salvage therapy because they decrease the cerebral blood flow as well. But we can do blood suppression with the help of barbiturate. Hyperventilation to the PCO2 of 30 to 32, and moderate hypothermia if needed as a salvage therapy. The patient, like after this tier 3 approach, and then barbiturate infusion stopped, and GCS was 8/15, and the tracheostomy was done. Though if the recommendation by this was not by Brain Trauma Foundation or any societies, but the data says that if you do the tracheostomy less than 7 days, within 7 days early tracheostomy, so the ICU ventilation stay and ICU length of stay decreases. Couple of two things on extracranial complication. In a respiratory management, we will maintain avoid hypoxia, hyperoxia, hypoventilation, hyperventilation. We can use the PEEP and recruitment maneuver, but keeping in view that if we go above 10 PEEP, then there will be raised ICP due to the decreased venous return. Fluid and transfusion, we will be giving crystalloid, isotonic, avoid albumin because it increases the mortality in traumatic brain injury patients. Renal complications, all TBI patients usually suffer 10% of AKI. Nutrition we need to start within 5 to 7 days. And coagulopathy, we already said that we should give transamine. And if the patient is already anticoagulant, we can reverse it with some. And if the patient is having damage control resuscitation, we can use 1:1:1 therapy. The last slide is this is the pharmacological drugs in TBI. People in our setup, our neurosurgeons usually use this vitamin B6, pyridoxine. They usually prescribe the amantadine. These all studies are done on animal models, which help in pyridoxine helps in the neurotransmitters, amantadine helps in maintaining the neurons recovery. But these are all experimental things. People have seen a little bit of difference. So giving pyridoxine means no harm to the patient. So we usually give in an ICU the pyridoxine and amantadine as well. But there are a couple of drugs people use for spasticity, delirium, quetiapine and everything. But these are not reinforced by any society till now. So in the end, in the summary, initial management, avoid and treat hypotension, hypoxia and anemia. Secondly, we have to treat the ICP. The number is 20. By the BTF, Brain Trauma Foundation, management of cerebral perfusion pressure, it should be 60 to 80. Monitoring, we have the intracranial monitoring, we can use subdural bolts or EVD in place, or other, we can do the optic nerve sheath diameter. Extracranial complication, I already explained, respiratory, fluid transfusion, AKI, nutrition and coagulation management. Thank you so much.
So, any question? Our expert panel is here.
I'll ask the expert panel. As soon as the patient comes with traumatic brain injury, should you rush the patient for CT scan, or you will have to wait for something?
So as I was saying earlier, so the golden hour of trauma. So in the initial first hour, it's very important to manage hypoxia and hypotension, because what the literature says, the single episode of hypoxia and hypotension would worsen the outcome in terms of the delayed neurological recovery by around 80%. So in initial hour of trauma, it's very important that you need to look at the A, B, C, and there is a logic behind, as I told you. So we need to treat actively the hypoxia and the hypotension, and we have discussed the the resuscitation goal in the initial hour. So there is no need of rushing towards the CT scan immediately.
And when should we repeat CT scan?
So as soon as your patient is stable, you have to look for the clinical sign, and then once you think that your patient is stable, and then definitely CT scan needs to be done. Patient should be shifted then under the monitoring and all those kind of stuff which you have achieved initially.
थैंक यू. मैंने ये इसलिए पूछा कि जहाँ मैं काम करती हूँ वहाँ पर CT स्कैन बार बार कराना बड़ा मुश्किल होता है. तो बहुत सारे स्टूडेंट्स वहाँ के बैठे हुए हैं. तो इनकी
So I was discussing in the trauma conference, I think last year. So it's very important for all of us, if we are sending our patients to the tertiary care center, so just do the basics, and that's the purpose. I think इस तरह की conference का ये purpose होना चाहिए. Take home message: please treat hypoxia, hypotension. Don't send your patient without intubation. Don't send your patient with an IV line. And it's a common scenario. We are receiving patient from the Balochistan, not intubated, not resuscitated. Similarly, from the lower Punjab, from the all the other kind of hospital setups in the Karachi. So I think basics are basics, and it's our responsibility to implement care bundles to look at those kind of aspects. As I've told you, the single episode of hypertension and the hypoxia would worsen the outcome by around 80%.
थैंक यू प्रयास. क्लिनिकल मॉनिटरिंग इज इम्पॉर्टेंट. उस पर आप डिसाइड करते हैं कि आगे क्या करते जाना है.
My question is towards Dr. Faraz, that tell us about this use of hypertonic saline. How much and what concentration and the time?
So first of all, it's very important to look at what's the indication. So as the settled guidelines are saying, so for initial resuscitation and for the initial management of your trauma patient, it can be done in any kind of neuro setup, in any kind of ICU setup. So it's not indicated prophylactically. But once you'll see that your patient is getting into worsening in terms of CT scan, worsening in terms of neurological, monitoring, pupils and all that, so you have to start the either mannitol or the hypertonic saline. So the literature, so hypertonic saline 3%, you have to see, you can, so if you run it at 1 mils per kg body weight, the 3% hypertonic saline, it would increase your sodium by around, the 1 mils per kg would increase the sodium of around 1. So it has to be run peripherally. If you have got peripheral line, has to be somewhere between 30 mils per hour. But if you have got central line, you can increase it a bit. But you have to set your target. So the target is either your serum osmolarity or either your serum sodium, which is around 155 millimoles per liter. And it's very important for us. So if you have, so the literature, what the literature is saying, you can use either mannitol or hypertonic saline. There is not much difference. But all those kind of side effects which are associated with mannitol, like hypotension, like electrolyte imbalance, renal failure, it's much lesser as compared to it's much lesser with the hypertonic saline in comparison to the mannitol.
What would?
So in my opinion, I think what I'm seeing, but it's in my current practice, I'll prefer mannitol. It all depends. So if you have got line, if you also, so my preferences would be, the hypertonic saline.
No, you have said both the things. Would you use mannitol or would you use hypertonic saline? And what is the recommendation for the junior colleagues? Which would be a safer bargain for the safety of the patient as a first line of defense, prophylactically or otherwise?
So one has to individualize. For say, if you need if you need immediate reduction in ICP, then mannitol would be the target. But giving the mannitol, you need to look at your hemodynamics, hypertension, and all those kind of stuff. But if you have got some time and if it has to be in a maintenance phase, I think better to be relying on the hypertonic saline.
What would be the most immediate?
Sorry, say again, sir.
Immediate complication of hypertonic saline.
So if you run it peripherally, maybe you might be ending up in having phlebitis through the peripheral vein.
So better give it through the central line. It should be preferred. The central line should be the.
I think we are running short of time. We have to start the new discussion. Thank you very much, the expert panel. Very nice discussion. Thanks
So it's important for us to look at the settled guidelines. It's a tier-based management of traumatic brain injury. So I think the take-home message for all of you to go through those guidelines. It's very important for us to understand those guidelines. Thank you.
Thank you very much for such a healthy and knowledgeable discussion. I would request Dr. Nasreen Laik to please join us here upon the stage for certificate distribution ceremony. A big round of applause, please. Respected chairs, please come in front to receive your certificates. Professor Naveed Masood. Respected Madam, Professor Zafia Safar. Thank you, Madam. Now I would like to request Dr. Nasreen to please give our certificates to the experts. Dr. Faraz Shafiq.
Session 6 was divided in two. So Dr. Talal will continue the session.
नहीं तो ये वाली सर्टिफिकेट के बाद नहीं होगा
नहीं
बाद में होगा ओके इट्स ओके वो करें कंटिन्यू
इन दोनों को हाँ बैठे रहने
मुझे बताया ठीक है तो अभी कंटिन्यू करेंगे ना ओके डॉक्टर आसिया तक And to the presenter, I would like to request the chairs to please present the certificate. Thank you. And thank you, sir. And experts can give me the certificate for moderator. Now we are moving towards the second case discussion and Dr. Talal will take over. Thank you.
Assalamualaikum. For the next session regarding the case-based discussion on the topic of pain, first I would like to call the expert panel. The first expert panel is Professor Gohar Afshan. She is the Tajuddin Hussain Jafar Endowed Professor of Anesthesia and Head of Pain Medicine, Aga Khan University Hospital, Pakistan. She is also a member of the Pain Management Committees, WFSA, and convener, Faculty of Pain Medicine, CPSP. She established the first pain setup at Aga Khan University Hospital, followed by the first pain fellowship program in Pakistan. She is the recipient of many national and international grants and is the author of more than 125 peer-reviewed publications. The second expert panel is Professor Asif Gulkiani. He is the consultant anesthesia and pain medicine, Behria International Hospital, Rawalpindi. He is also a supervisor of FCPS pain medicine. He is also a member of pain medicine committee, CPSP. He is a regular speaker in national pain conferences and symposiums. He has also organized a number of local and national workshops on intervention pain medicine. For the talk, I would like to invite Dr. Tanveer Beg. He is an assistant professor in Department of Anesthesiology, Surgical Intensive Care Unit and Pain Management, Aga Khan University Hospital. He has been affiliated for more than a decade in the field of pain management. Dr. Tanveer.
Assalamu alaikum everyone and good morning. This session is not like I will going to present in presentation, but it's a totally interactive session in which I will involve audience also, and then we will go to the expert for their expert opinion. So this is a case-based discussion. I will going to present a small case which I need to ask you what's your opinion about this case, what is this case. Then we will elaborate it, we will go and dig down the diagnosis, differential diagnosis, then pathophysiology, then obviously treatment, like that. So it's a totally interactive session where you give me input also, then we will go to the expert, what's their opinion, because it's a difficult case in chronic pain patients. As you see, it's a 32-year-old patient with a complaint of pain, and actually pain physician usually encounter these kind of patients. Like you can see, the pain is continuous and sharp in nature. Movement of the arm aggravate. With the movement, pain is aggravated there. Even a small touch ignite or stimulate the pain. It's very strange. How can a small touch aggravate or stimulate the pain? Is there any problem in the perception of the pain? Is there any problem in the some receptors in the pain? Or what else is going on? Because we are not expecting slight touch will stimulate the pain. And the next thing is on examination, as you will see, that patient is edematous, the arm is edematous, and warm and glistening, you can see there. On history, if you will go through it, that status post patient operated 3 months back with the multiple wound debridement, and then the orthopedic colleague fixed that radius ulna. So what would be the diagnosis would be? So first we will go to the diagnosis, then differential diagnosis, then obviously diagnostic criteria, what diagnostic tools and means are available, then proposed pathology, and then obviously we will go to the treatment. So obviously would be the answer would be, what do you think about this? What is CRPS? Anybody in audience? सन्नाटा ये काम नहीं कर रहे क्या? सर ये तो आप बताएंगे अभी, पहले इनको बताने से चलें. सो ऑडियंस में बिल्कुल एक कोलीग ने बताया कि क्रोनिक पेन डिसऑर्डर है. ऑब्वियसली अगर क्रोनिक पेन डिसऑर्डर है तो क्रोनिक पेन डिसऑर्डर तो ये देखिए कि और बहुत सारे हैं. मिसाल के तौर पर रेडिकुलोपैथी इज़ दियर, persistent post surgical pain is there, and obviously compartment syndrome is there, and vascular disorder sometimes present like this, and progressive demyelinating disease usually present like this. and the painful post-traumatic osteoporosis patient usually present or came to you or came to the clinic like this. And even post-stroke burn syndrome, if you will go through that after a stroke patient starts complaining burning is there in the affected limb. So how will we differentiate between these big list of the differential diagnosis, whether patient is having all these things or complex regional pain syndrome? If you have any idea, or I will go to the expert also. Acha.
It's just one thing I would like to say, because I know this is a anesthesia forum, so I don't expect that the people sitting here in anesthesia, they can easily talk about the chronic pain. So certainly some of maybe here are interested, so we would like to make it some simple form of complex regional pain syndrome, so that everybody is comfortable, and if they can share anything, because this is not the right forum for talking about a detail of this CRPS, which is not everybody's speciality. So make it very simple so that people can understand.
In my opinion, it's a problem which is, as it's shown by the name of it, it's a complex issue and not very common. Even for those who are practicing pain for a long time, it's not a very common issue. So, but we should at least sensitize people that it can occur. It can occur after injury, trauma, and what are the salient features and management.
So obviously, if you will say the complex regional pain syndrome, रेडिकुलोपैथी में क्या है कि रेडिकुलोपैथी में एक नर्व डिस्ट्रीब्यूशन में आपको पेन मिलेगा, लेकिन कॉम्प्लेक्स रीजनल पेन में एज सच इस तरह की चीज़ नहीं होगी. अगर परसिस्टेंट पोस्ट सर्जिकल पेन की बात करें तो उसमें जो है सर्जरी के साथ ही पेन जो है वो कंटिन्यूसली चलता रहेगा. अगर थोरेसिक आउटलेट जो है वो उसकी बात करें तो ऑब्वियसली इफ़ यू गो थ्रू द चेस्ट एक्सरे यू विल फाइंड द एसेसरी रिलीफ वुड बी देयर. अगर हम आगे कंपार्टमेंट सिंड्रोम की बात करें तो वो फ़ौरन ही पोस्ट सर्जिकल आपको पेशेंट प्रेजेंट कर देगा. अगर वेस्कुलर डिसऑर्डर तो उसके लिए हम इन्वेस्टिगेशन के थ्रू जो है एंजियोग्राफी करके वी कैन डिफरेंशिएट के दिस इज़ वेस्कुलर पैथोलॉजी और कम्प्लेक्स रीजनल पेन सिंड्रोम. इसी तरह जो है प्रोग्रेसिव डीमाइलिनेटिंग डिजीज़ में ऑब्वियसली पेशेंट के बायलैटरल लिम्स या बॉडी के दूसरे पार्ट्स भी इन्वॉल्व होंगे. अगर पेनफुल पोस्ट ट्रॉमेटिक ऑस्टियोपोरोसिस में देखें तो उसमें जो है अगर आप एक्सरे कराएंगे तो सिंपली यू विल गेट द ऑस्टियोपोरोसिस इज हियर. एंड पोस्ट स्ट्रोक बर्न सिंड्रोम में ऑब्वियसली यू विल गेट द हिस्ट्री ऑफ स्ट्रोक ऑल्सो. उसमें पेशेंट की स्ट्रोक की हिस्ट्री होगी और उस खास एरिया में जो पेशेंट का वीक एरिया है पेशेंट विल कंप्लेन ऑफ बर्निंग सिंड्रोम. Then type of the CRPS. There are two types of CRPS, CRPS 1 and CRPS 2. CRPS 1 में simply आपको पेशेंट में जो है कोई ऐसी फाइंडिंग नहीं मिलेगी कि डायरेक्ट नर्व इंजरी हो. यूजुअली मे बी द स्मॉल ट्रिवियल इंजरी वुड यू फाइंड देयर. एंड CRPS 2 में ऑब्वियसली बिल्कुल क्लियर कट आपको हिस्ट्री मिलेगी, जैसे गन शॉट है, ट्रॉमा है और फ्रैक्चर है जो डायरेक्टली नर्व को इंजर कर रही है. तो डायग्नोस्टिक टेस्ट, मल्टीपल डायग्नोस्टिक टेस्ट आर अवेलेबल लाइक प्लेन रेडियोग्राफ. यू विल गो थ्रू दैट, यू विल फाइंड ऑस्टियोलाइटिक चेंजेस ओवर देयर. क्वांटिटेटिव सेंसरी टेस्टिंग जिसमें आप सेंसरी टेस्ट कर सकते हो. बोन मिनरल डेंसिटी यू विल फाइंड लेस डेंसिटी ओवर देयर. MRI में यू विल फाइंड द इफ नर्व entrapment इज देयर. Like QSART test, it's a rare test, quantitative pseudomotor axon reflex test, जिसमें पोस्ट गैंग्लियोनिक जो है एक्सॉन को जो है आप टेस्ट कर सकते हो. देन थर्मोग्राफी, बिकॉज थर्मोग्राफी में आप पेशेंट के दूसरे आर्म के टेम्परेचर से इस आर्म का या अफेक्टेड एरिया का टेम्परेचर डिफ्रेंशिएट कर सकते हैं. देन लेज़र डॉपलर टेस्ट है जिसमें जो है आप फ्लो वगैरह को मॉनिटर कर सकते हैं. Then nerve conduction study would tell you कि नर्व कहीं इंट्रैप्ट तो नहीं हो रही है. Then electromyography obviously कि नर्व कहीं अगर इंट्रैप्ट है तो मसल की डीमाइलिनेशन या मसल वीकनेस डेवलप नहीं हो गई है. डायग्नोस्टिक क्राइटेरिया, इसमें 3 डायग्नोस्टिक क्राइटेरिया. इनिशियली द वेलमेड क्राइटेरिया कम अप एंड देन नेक्स्ट 1994 में IASP एक criteria लेके आई, then Budapest criteria is the more prevalent criteria which we all are following. Wellbeing criteria, as you see, things are there जिसमें 4 में से अगर एक चीज़ 2 चीज़ें आपको मिल जाती हैं तो आप जो है पेशेंट को लेबल कर सकते हैं कि उसको कॉम्प्लेक्स रीजनल पेन सिंड्रोम है, और सिंपली अगर पेशेंट को वो पेन कंटिन्यूसली हो रहा है तो ये वेलमेंट क्राइटेरिया है। ISP में उसने मज़ीद इसमें ऐड कर दिया था कि इसमें कोई ना कोई इनसेटिंग स्टिमुलस होना चाहिए जिसकी वजह से कि ये पैथोलॉजी स्टार्ट हुई है। लेकिन सबसे जो प्रिवेलेंट और सबसे एक्सेप्टेड जो क्राइटेरिया है वो ऑब्वियसली बुदापेस्ट क्राइटेरिया है, और जिसमें आप जो है कंटिन्यूइंग पेन यू विल फाइंड देयर, एंड देन out of 4 if you are getting 2 or 3 signs and symptoms are there, then obviously you can conclude that patient is having a complex regional pain syndrome. Pathology is very important. पैथोलॉजी में ऑब्वियसली जैसे डॉक्टर गौहर ने कहा कि आप सब जाहिर सी बात है पेन फिजिशियन नहीं है, लेकिन मैं अपने एक्सपर्ट से भी इसमें और मैं भी कोशिश करता हूँ आपको एक्सप्लेन करने की। इसमें मल्टीपल थ्योरीज आई, जैसे 1994 में गोस्टीन एक थ्योरी लेके आए जिसमें एपीफेसिस डेवलप हो जाते हैं। एपीफेसिस लाइक अगर नर्व टू नर्व कनेक्शन है तो आप कहते हैं इसको साइनेप्सिस हैं, लेकिन अगर कहीं ट्रॉमा हुआ है नर्व का और वो नर्व जो है किसी आम टिश्यू से साइनेप्स कर रही तो उसको एपीफेस कहते हैं, एंड दैट्स डिफरेंट थिंग। और उसका ऑब्वियसली जो कम्युनिकेशन का तरीका है वो भी डिफरेंट है। इसी तरह जो है फिर 86 में दूसरी थ्योरी आई, उसमें उन्होंने इससे थोड़ा सा आगे जाके बात की कि शायद जो है नर्व की इंजरी की वजह से ऐसा हो रहा है। फिर 1991 में डिफरेंट इससे थ्योरी आई, लेकिन मैं आपको कंक्लूजन इसका बता दूं कि समरी सिंपल ये है कि अगर कहीं भी नर्व इंजरी होती है तो ऑब्वियसली जिस तरह ब्लड ब्रेन बैरियर होता है इसी तरह नर्व बैरियर जो है ब्लड बैरियर होता है। अगर वो बैरियर ब्रीच कर जाए तो ऑब्वियसली द ब्लड विल बी इन कंटिन्यूटी और डायरेक्ट कंटेक्ट विद दैट नर्व फाइबर, और उस नर्व फाइबर में जो चेंजेस आती हैं उस पे जो है अल्फा-2 एड्रेनल रिसेप्टर डेवलप हो जाते हैं। दैट्स वाई सर्कुलेटरी एड्रेनलिन or noradrenaline continuously stimulate that nerve fiber, and that nerve fiber then go to the DRG level and wide dynamic neurons को stimulate करना शुरू कर देता है। That's why patient is continuously having a pain, and then from DRG जो second order neuron है और then third order neuron brain में वो plasticity की changes होना शुरू हो जाती हैं। That question should come in your mind कि why small touch is perceived like a pain. मीन अगर पेशेंट को आप टच कर रहे हो या उसको मूवमेंट दे रहे हो तो वो पेन कैसे परसीव हो रहा है, बिकॉज यू आर नॉट टचिंग द पेन रिसेप्टर्स, यू आर नॉट स्टिमुलेटिंग द फ्री नर्व एंडिंग्स, यू आर नॉट पुशिंग द पेशेनियन कॉर्पसेस। द थिंग इज पेशेंट को जो आपने टच किया है वो सिंपली DRG तक तो सेम जाता है, बट DRG के लेवल पे जहाँ जो है मल्टीपल न्यूरॉन्स हैं वहाँ प्लास्टिसिटी डेवलप हो जाती है। प्लास्टिसिटी सिंपली आप इस तरह समझ सकते हैं कि जिस तरह से एक सेंटर बॉक्स के अंदर मल्टीपल वायर्स हैं, अगर वो प्लास्टर्ड हो जाएं तो आप कोई एक बटन पुश करेंगे और यू विल फाइंड के कोई लाइट के बजाय फैन ऑन हो जाए या फैन के बजाय लाइट ऑन हो जाए। दैट्स प्लास्टिसिटी सिंपली कि आपने टच किया है बट यू आर गेटिंग अ परसेप्शन ऑफ पेन। आपने पेशेनियन कॉर्पसेल्स को पुश किया है बट यू आर गेटिंग अ पेन, लाइक ये DRG पे हो रहा है, या फिर ये सेंट्रल प्लास्टिसिटी ब्रेन में डेवलप होती है। दैट्स प्लास्टिसिटी एक्चुअली आंसर वाई CRPS इज हैविंग दिस काइंड ऑफ साइन एंड सिम्टम। ट्रीटमेंट मल्टीपल ट्रीटमेंट ऑप्शंस हैं। हम अपने एक्सपर्ट्स की तरफ भी चलते हैं कि आप लोग यूजुअली अगर CRPS के पेशेंट देखते हैं तो किस तरह आप लोग प्रोसीड करते हैं। डॉक्टर गौर।
Okay, so first of all, I would just thank you very much, Dr. Tanveer. So I would just like to, because this is anesthesia forum, so I would like to take this opportunity to explain that this is currently the chronic pain. I'm not talking about specifically the CRP, as the chronic pain has been included in the list of the chronic medical diseases like diabetes, hypertension and things like that. So the chronic pain is nowadays state of, is a serious affair because usko ab medical disease mein aa gaya ye. It is no more symptom, this is a medical disease. और क्रॉनिक है तो जैसे हाइपरटेंशन, डायबिटीज़, रीमेटॉइड, इनको क्रॉनिकली ट्रीट करना होगा. सो दिस सिमिलरली द क्रॉनिक पेन. Now, in the chronic pain, this CRPS, which Dr. Tanveer chose this topic, this is one of the primary chronic pain, one of the 5 chronic pain. This is a very, very important to remember. The 4 या 5 जो primary causes होते हैं chronic pain के, this is one of them. And what Dr. Tanveer was talking about plasticity, this is very, very important to understand that we as anesthesiologists, right, left and center, we are dealing pain. In ICU, in theatre, in post-op, in recovery. But we are dealing normally the normal pain. This is the normal nociceptive is called the normal pain. This is just we are dealing the normal pain के होना है, ये process है, ये nociception है, ये inflammation है. But here we are talking about the abnormal pain. This is not a normal pain. This is an abnormal pain that actually we perceive at our brain at different multiple abnormal links, or crosstalk is a crosstalk of the different connections. And because of this crosstalk, currently in the because neurosciences is one of my favorite subject. So in the neurosciences, the majority of this research is being done how these abnormal sensations people feel, like allodynia, कि मेरा कपड़ा ही मुझे बुरा लग रहा है, and it is something like that. So these are emerging area. First of all, that this is a chronic disease, just like a diabetes and hypertension, so don't you remember. Secondly, there are a lot of research, because everything is brain. So the cognitive level पे सब कुछ हो रहा है, it is peripheral, is nothing much more. जो डॉक्टर तनवीर ने हाइपोथेसिस की बात की है, सो आई वुड जस्ट लाइक टू ऐड कि वी always we talk about the inflammation, but here we are added inflammation is called the neurogenic inflammation. It is not a simple inflammation जो हमने यहाँ चोट लगी, यहाँ पे सब्सटेंस भी रिलीज हुआ, यहाँ we are talking about DRG पे भी सब कुछ होगा. And that's why this sensory sensitization और post operative pain जो रह जाते हैं. Now यहाँ जो डॉक्टर तनवीर ने हमसे पूछा as expert, so this is certainly a challenge. So taking a good clinical history. So as a physician, जो हमारे पास सबसे अच्छा acumen is a history taking and the examination. Because in CRPS, no investigation would guide you. Maybe you did all the investigation to rule out the problem, but your clinical history and examination would decide whether he is suffering from CRPS or not. आगे डॉक्टर कयानी बात करते हैं, then I can come back.
सर आप कुछ
If we have a time.
Thank you so much. I totally agree with Dr. Kaur. CRPS मेरे ख्याल में, या जनरली मेरे ख्याल है, जब हम डायग्नोसिस की बात करेंगे तो CRPS is a sort of extension of a neuropathic pain. बेसिकली तो हमें पहले ये देखना है कि ये न्यूरोपैथिक पेन्स कौन से हैं और जो नोसिसेप्टिव पेन्स हैं वो कौन से. ठीक है, तो हमें पहले तो डिफरेंशिएट करना है, बिकॉज दोनों का ट्रीटमेंट अलग अलग है, दोनों की मेडिसिन अलग अलग है. जो नोसिसेप्टिव पेन्स हैं उसमें तो हमारा पैरासीटामोल और ब्रूफेन और ये चीज़ें सब काम का, एनसेड्स काम करेंगे. इसमें एनसेड नहीं काम करेगा, न्यूरोपैथिक पेन नहीं करेगा. इसका डिफरेंट सेट ऑफ मेडिसिन है, डिफरेंट सेट ऑफ टेक्निक्स है जो इसको, और वो प्राइमरीली ये है कि नर्व इंजरी हुई और वहाँ से मसला शुरू हुआ. CRPS में भी यही है कि इनिशियली नर्व इंजरी हुई, अब उसको 2 कैटेगरीज में डिवाइड किया, CRPS 1, CRPS 2. CRPS 1 में कोई ऑब्वियस नर्व इंजरी नहीं, डिफाइनेबल नहीं होती, लेकिन स्टिल हमें समझते हैं कि जो छोटी नर्व्स हैं, जो बारीक नर्व्स हैं, कि इंजरी बाजू में हुई, फ्रैक्चर हुआ, फ्रैक्चर के बाद वहाँ पे कुछ मे बी को सर्जरी हुई या नहीं हुई, दोनों सूरतों में इमोबिलाइज कर दिया, तब भी फ्रैक्चर की वजह से कुछ नर्व्स छोटी जो हैं वो डैमेज हो गई. मुझे जो सबसे पहला केस मैंने याद पड़ता है, जब मैं हाउस जॉब कर रहा था ऑर्थोपेडिक्स में, प्रोफेसर सलीम साहब थे मुल्तान में, निस्तर में. तो एक दिन हम OPD में उनके साथ बैठे थे, तो एक पेशेंट हमने देखा जिसको बाजू का फ्रैक्चर हुआ था, डिस्टल रेडियस का, और उसके बाद वो आया तो बहुत पेनफुल भी था, स्वोलन था, और बाकी कोई ख़ास उसको सर्जरी भी नहीं हुई. तो सलीम साहब ने मुझे कहा कि इनको मेहदी साहब के पास भिजवा दे, वो इसको इंजेक्शन लगाएंगे. और उस वक्त जो इसका नाम था इस कंडीशन का, इसको कहते थे RST, भी बाद में आया, सूडेक्स एट्रोफी. अब ये मतलब जो 19वीं सदी में कहीं आखिर में जाके एक मिस्टर सूडेक थे जिनके नाम से ये हुआ, कि उन्होंने एक्सप्लेन किया कि ये नॉर्मल ट्रॉमा से बियॉन्ड कोई चीज़ है. तो उसके बाद जाके 1900 के बाद जो कुछ टाइम में आया, तो फिर उसको देखा कि इसके अंदर कुछ सिंपैथेटिक्स भी इन्वॉल्व है, सिंपैथेटिक नर्व्स इन्वॉल्व है. तो उन्होंने कहा और उसका कुछ रिफ्लेक्स मैकेनिज्म है जो अभी हम उसको बेहतर एक्सप्लेन कर रहे हैं आज, लेकिन उस वक्त उन्होंने कहा कि रिफ्लेक्स सिंथेटिक डिस्ट्रोफी, इसलिए डिस्ट्रोफिक चेंजेस भी आती है और रिफ्लेक्स सिंथेटिक उसके रिफ्लेक्स। और फिर बहुत लेट जाके ये जाके 1994 में जो इंटरनेशनल एसोसिएशन फॉर स्टडी ऑफ पेन है, उन्होंने कहा कि जी अच्छा, उसके अलावा ये था कि जो मेजर नर्व्स की इंजरी जो हमें नज़र आती है, कोई बड़ी नर्व शार्टिक नर्व इंजर हो गई कुछ, उसका भी इसी तरह से सिम्टम्स होते थे, इसी तरह से प्रॉब्लम थे। तो उन्होंने ये कहा कि उसको लेकिन कॉजेल्जिया कहा जाता था, कि वो कॉजेल्जिया है और ये वाला जो है जिसमें नर्व इंजरी नज़र नहीं आती, ये जो है ये है RSD,
टाइप 1 के लिए
टाइप 1। अब उसको अपने फिर उन्होंने दोनों 1994 में इंटरनेशनल एसोसिएशन स्टडी ऑफ पेन ने एक टास्क फोर्स बना के सब मिले और उन्होंने इसके ऊपर काफ़ी गौर फिक्र करने के बाद दोनों जो कंडीशंस थी उनको मिक्स कर दिया, मिला दिया और उन्होंने कहा एक ही हेडिंग में ले आओ, इट्स ए कॉम्प्लेक्स रीजनल पेन सिंड्रोम। अब ये बेसिकली जो उन्होंने मिलाया है ये फॉर डायग्नोस्टिक पर्पसेस है कि क्या हम पॉसिबल है अभी तक कि हम सारे दुनिया में किसी भी कोने में कोई साइंटिस्ट या कोई क्लिनिशियन है वो बैठ के जब ये देखेगा तो क्या हम सारे एक ही डायग्नोसिस पे पहुंचेंगे या नज़दीक पहुंचेंगे। तो इसलिए उसको मिलाया। अच्छा, लेकिन फिर 2004 में अगेन जाके जब देखा कि इसमें अभी तक क्लैरिटी उस तरह से नहीं है, उसको फिर रिवाइज किया, वो जो जिसको बुडापेस्ट डिक्लेरेशन हम कहते हैं कि वह सारे बुडापेस्ट में इकट्ठे हुए, फिर उसको तो 2012 में जाके वो चीज़ जो है ना रीडिफाइन हुई। बेसिकली यही है कि इसके अंदर सेंसरी चेंजेस जो आ रही हैं, जैसे हम कह रहे हैं कि उसका एलोडीनिया है, हाइपर सेंसिटिव हो जाती है, टच के बजाय वो पेन फील होता है और थोड़ा पेन जो है वो ज़्यादा फील होता है, जिसको हाइपरएनस्थीसिया कहते हैं।
ऑडियंस के लिए, क्योंकि ऑब्वियसली एनेस्थेटिस्ट हैं, एलोडीनिया इनको थोड़ा सा
यही बता रहा हूँ कि जिसको टच जो है वो पेन फील होता है, वो एलोडीनिया।
सही,
क्या आप हाथ लगाएंगे जिसको जहाँ पेन नहीं होना चाहिए वो भी पेन हो जाता है, लेकिन जहाँ पेन थोड़ा पेन है वो आपको ज्यादा महसूस होता है, उसको हाइपरएनस्थीसिया कहते हैं। ये तो बेसिकली हर न्यूरोपैथिक के बेसिक साइंस तो यही है ना, ये जो सिम्टम्स भी है साइंस भी। तो लेकिन इसमें और क्या हुआ कि इसमें स्वेलिंग भी हुई, सूडोमोटर चेंजेस, उसके टेम्परेचर चेंजेस आ गई, इन्फ्लेमेशन में भी टेम्परेचर चेंजेस आती है, लेकिन ये इन्फ्लेमेशन जो इन्फेक्शन की
थोड़ा
वजह
सा
से।
ट्रीटमेंट बता दें अगर आप।
सॉरी,
थोड़ा सा ट्रीटमेंट बता दें अगर, तो लोगों के लिए थोड़ा।
मैं ट्रीटमेंट तो और भी गंभीर है तो
अच्छा।
लेकिन यह है कि बात पहले समझ तो है ना कि हमने डायग्नोज कैसे करना है। किसी को भी नजर आए तो वो उसको कैसे उसको कहेगा कि ये CRPS हो गया, ये न्यूरोपैथिक पेन, ठीक है ना। तो डायग्नोज नहीं करेंगे तो ट्रीट कैसे करेंगे।
और डॉक्टर सफिया के जवाब में कि ये CRPS में बहुत सारी चीज़ें जब सारी आप एक्सक्लूड कर देते हो, जो हमने डिफरेंशियल की बात की है, तो ऑब्वियसली फिर CRPS ही उसको फिर लेबल कर देते हैं। जैसे रेडिकुलो सबसे डिफरेंशिएट करने के बाद एक्सक्लूजन ऑफ ऑल क्राइटेरिया के बाद सिंपली जैसे बुडापेस्ट क्राइटेरिया भी बाज़ जगह पूरा नहीं होता था, तो फिर उसको हम कॉम्प्लेक्स रीजनल पेन सिंड्रोम कर देते हैं। डॉक्टर सफिया ने ट्रीटमेंट के लिए
पहले हम वहाँ पहुँचेंगे तो फिर हमें तो पहले नाम से कॉम्प्लेक्स है, इसका मतलब ट्रीटमेंट भी कॉम्प्लेक्स।
टाइम कम है आपके,
टाइम कम है तो खत्म कर लेते हैं। इसकी ट्रीटमेंट जो है ना जस्ट लाइक न्यूरोपैथिक पेन ही स्टार्ट करेंगे। बेसिकली न्यूरोपैथिक पेन है, वही दवाइयाँ इस्तेमाल होगी जिसमें एंटी कन्वल्सेंट्स हैं, एंटी डिप्रेशेंट्स यूज़ करते हैं। लेकिन आम तौर पे अगर वेल एस्टेब्लिश्ड है, पुराना है, 2 टाइप का है, एक्यूट है, डिस्ट्रोफिक है, एट्रोफिक है, वो इसके 3 टाइप्स हैं। तो डिपेंड्स के कितना पुराना है उतना ही उसकी ट्रीटमेंट मुश्किल होगी। और इसके अंदर इसके अलावा मेडिसिन के अलावा लोकल ब्लॉक्स, रीजनल ब्लॉक्स, वो सब चीज़ें इफेक्टिव हैं। बट जो सबसे जो अल्टीमेटली जो एविडेंस बेस्ड ट्रीटमेंट समझी गई कि जो वेल एस्टेब्लिश्ड है, जो नहीं ठीक हो रहा, उसको जो स्पाइनल कॉर्ड स्टिमुलेशन है उसके लिए फॉर RSD टाइप 1 जो है उसके लिए तो इसकी जो है एविडेंस वो कैटेगरी A एविडेंस है स्पाइनल कॉर्ड स्टिमुलेटर के लिए, और टाइप 2 जिसको कॉजेल्जिया कहते हैं उसके लिए टाइप जो लेवल D एविडेंस है इसका। लेकिन स्पाइनल कॉर्ड स्टिमुलेटर ही अल्टीमेटली बनता है अगर नहीं ठीक हो रहा, रिफ्रैक्टरी है, नहीं ठीक हो रहा। बट मोस्ट ऑफ द टाइम जब स्टार्ट करते हैं तो हम न्यूरोपैथिक पेन की तरह ही ट्रीट करते हैं।
लेकिन डॉक्टर सफिया अगर हम यानी आम जो पेन फिजिशियन है या एनेस्थेटिस्ट जो स्टार्ट करना चाहें तो उसके लिए यानी जैसे मैंने ट्रीटमेंट के लिए जो ये एक स्लाइड शो कर रहा हूँ जिसमें साइकोलॉजिकल ट्रीटमेंट का एक डोमेन आ रहा है, सिंपल बीच में जो है रीएक्टिवेशन डीनर्वेशन का है, फिर एक दूसरा जो ब्लॉक है वो सिंपल इंटरवेंशन का है, यानी आप साथ साथ उसका साइकोलॉजिकल ट्रीटमेंट करेंगे, साथ साथ डीनर्वेशन या डीएक्टिवेशन करेंगे और फिर इंटरवेंशन में ऑब्वियसली अगर अपर लिम है तो स्टीलेट गैंग्लियन ब्लॉक, सिंपैथेटिक ब्लॉक, पहले किसी ज़माने में सिंपैथोलाइटिक टेस्ट भी करते थे ताकि ये देख लें कि सिंपैथेटिक ड्रिवन पेन है, इससे स्टार्ट करेंगे। जहाँ तक रिफ्रैक्टिव केसेस का ताल्लुक है तो रिफ्रैक्टिव केसेस में जैसे सर ने हाईलाइट किया कि स्पाइनल कॉर्ड स्टिमुलेटर है, बल्कि रिसेंटली जो है इस जो स्टेट्स में इस वक्त अभी भी इनरोल हो रहे हैं पेशेंट, जो काम हो रहा है वो हो रहा है कि पेशेंट को जो है ट्रांसक्रेनियल डीप ब्रेन स्टिमुलेशन, जिसके के अच्छे रिजल्ट्स हैं। लेकिन अब कैटामीन का भी रोल आ गया है इसमें, और कैटामीन जो है 0.5 मिलीग्राम पर केजी बॉडी वेट के हिसाब से डिवाइडेड डोजेज में फॉर 3 to 5 डेज दे रहे हैं और उसके अच्छे रिजल्ट्स हैं। इनफैक्ट आई माई सेल्फ यूज डेक्समेटामोडिन ऑल्सो एंड गुड रिजल्ट्स आर देयर।
थैंक यू तनवीर।
हाँ भाई, कुछ पूछोगे?
थैंक यू वेरी मच। सॉरी मैंने आपको बीच में इंटरप्ट कर दिया था। ये इसलिए कि मेरे पास भी एक पेशेंट आता था ऐसे CRPS का, उसकी माँ लेके आती थी, उसको 20 साल का लड़का, गधे गाड़ी से उसकी चोट लगी थी और वो यूँ अपना हाथ पकड़ के लेके आता था और उसकी माँ कहती थी इसका हाथ कटवा दो, किसी तरह इसका हाथ कटवा दो, ना ये सोता है ना कोई काम कर सकता है, हर वक्त रोता रहता है दर्द से, इतना सीवियर पेन होता है इसमें। और मेरा तो बिल्कुल बेचैन हो गया कि इसको हाथ कैसे कटवाते हैं इसका। फिर हमने अपने तौर पे जो जो ट्रीटमेंट उन्होंने बताया सब बारी बारी करते रहे। कुछ दिनों उसको फ़र्क पड़ा, फिर वो दोबारा आया 3-4 महीने के बाद, इस तरह वो मुस्तकिल आता रहा।
हाँ, लेकिन डॉक्टर सफिया रिसेंटली हमने कैटामीन जो यूज़ करना शुरू किया,
कैटामीन भी यूज़ किया
IV, और कंटिन्यूसली जैसे डेली जो है 40 मिलीग्राम का एक पाउच देते 5 दिन तक दिया तो काफ़ी बेहतर रिजल्ट हैं।
चले, थैंक यू वेरी मच। थैंक यू तनवीर, थैंक यू क्यानी साहब, गौहर।
I would request the expert panel to please, I would request the chairpersons to please come forward and hand over the certificates to the expert panel. Professor Asif. Professor Gauhar Afshar. Dr. Tanveer Beg, please to receive. And myself.